You had the surgery? You did the physical therapy? You followed every single instruction your doctor gave you. And yet, here you are, still in pain, maybe even in more pain than before. If that sounds familiar, you are not alone. And more importantly, it is not your fault every year. Millions of people over the age of 60 undergo knee replacements, hip replacements, rotator cuff repairs, and spinal decompressions. And a shocking number of them. We're talking studies showing failure rates anywhere from 20 to 40% in older patients. End up back in their doctor's office asking the same question. Why didn't it work? Today, I'm going to tell you something that most orthopedic surgeons don't have time to explain in a 15-minute appointment. There is a biological reason, actually several, why these procedures that work beautifully in a 40-year-old often fall short in someone over 60. And once you understand it, everything changes. How you prepare for surgery, how you recover, whether you even need surgery in the first place. Stay with me. This is the video I wish someone had made for my patients years ago. But real quick before we dive in, if you're new here, welcome. This channel is all about giving you honest, practical health information that actually helps you make better decisions for yourself and your family. We are on a mission to reach 1,000 subscribers, and every single person who joins this community genuinely matters to us. So if you find today's video helpful, please hit that subscribe button and ring the notification bell. It costs you nothing and it means the absolute world to us. Okay, now let's really get into it. Segment 2. The big picture. Why surgery isn't a magic fix. Let's start with something fundamental that gets lost in surgical consultations. When a surgeon replaces your knee or repairs your rotator cuff, they are fixing the structure, the hardware if you will. They're replacing a worn-out hinge with a new one. They're stitching together a torn tendon. But here's the key insight. Your body is not just a machine. Your joints don't exist in isolation. They are embedded in a living system, connected to muscles, nerves, cartilage, connective tissue, bone density, immune function, and hormonal balance. And after age 60, that system has changed dramatically. Imagine you have a leaking pipe in your house. You hire a plumber to replace the pipe. That's the surgery. But if the water pressure throughout the whole house is wrong, if the surrounding walls are rotting, if the foundation has shifted, replacing just the pipe doesn't solve the problem. That's exactly what's happening in millions of older patients. The surgery was technically successful, but the system the surgery was placed into wasn't ready for it, or couldn't support it. Let's break down the specific reasons why. Segment 3. Reason number 1. Sarcopenia, the silent muscle thief. The first and arguably most important reason is a condition called sarcopenia. And I'll bet most of you have never heard that word from your orthopedic surgeon. Sarcopenia is the age-related loss of muscle mass and strength. It begins as early as your 30 seconds, but after age 60, it accelerates dramatically. The average person loses 3 to 5% of their muscle mass per decade. And that number gets worse with inactivity, poor nutrition, or chronic illness. Now, why does this matter for surgery? Because muscles are the shock absorbers and stabilizers of every joint in your body. When you have a knee replacement, the artificial joint is designed assuming that the surrounding muscles, the quadriceps, the hamstrings, the calf, will properly support and guide the new joint through movement. But if those muscles are depleted, weakened, or atrophied, the joint doesn't move the way it was designed to. It gets pulled off axis. It experiences uneven pressure. The result? Persistent pain, instability, and in some cases, accelerated wear on the implant itself. A 2021 study published in the Journal of Arthroplasty found that patients with significant preoperative muscle weakness had substantially worse outcomes 12 months after total knee replacement, regardless of how perfectly the surgery was performed. The surgeon did their job perfectly. The muscles just couldn't hold up their end of the bargain. What to do about it? If you are considering joint surgery, ask your doctor about prehabilitation, strength training specifically designed to build up the muscles around the affected joint before you go under the knife. Studies consistently show that patients who do prehab recover faster, experience less pain, and have better long-term outcomes. If you've already had surgery, targeted physical therapy focused on rebuilding muscle, not just range of motion, is critical, and don't stop after the insurance-covered sessions run out. Segment 4. Reason number 2. Bone quality decline. The second hidden factor is bone quality, specifically a decline in bone density that goes far beyond what most patients are told. Most people have heard of osteoporosis, but there's a spectrum of bone health that isn't always addressed before joint surgery. When a hip or knee implant is placed, it needs to bond with the surrounding bone, a process called osseointegration. In younger patients with healthy, dense bone, this process happens reliably and quickly. The implant integrates firmly and stays put. But in patients over 60, especially women post-menopause, or anyone who has been sedentary or on long-term corticosteroids, the bone can be too porous, too weak, or too compromised to hold the implant securely. This leads to something called aseptic loosening, where the implant gradually loosens from the bone over time, not from infection, but simply because the bone couldn't hold it. It's one of the leading causes of revision surgery, meaning a second operation to fix the first one. A 2019 review in Bone and Joint Research found that osteopenia, the stage before full osteoporosis, was present in a significant portion of patients who required revision surgery within 10 years of their primary procedure. The takeaway here is critical. Before any joint replacement surgery, ask your doctor for a DEXA scan. That's a bone density scan. It costs very little and takes about 15 minutes. If your bone density is low, addressing it before surgery through medication, resistance exercise, calcium, vitamin D, and vitamin K2 can meaningfully improve your surgical outcomes. This is standard of care in some countries. In others, it's still hit or miss. You may need to advocate for yourself. Segment 5. Reason number 3, chronic inflammation. Now we get to one of the most fascinating and underappreciated factors, and the one that I think explains the most failures overall. Chronic systemic inflammation. Here's something that might surprise you. Surgery doesn't reduce inflammation. In the short term, it causes massive inflammation. That's a normal part of healing. But for it to work properly, the inflammatory response needs to resolve. It needs to peak, do its job, and then quiet down. In older adults, this process is frequently dysregulated. Researchers call this phenomenon inflammaging, chronic, low-grade inflammation that persists in older bodies and doesn't resolve the way it should. This matters enormously for surgery because, first, chronic preoperative inflammation means your tissues are already in a stressed, reactive state before the surgeon even makes the incision. This impairs the initial healing response. Second, post-operative inflammation, which is supposed to resolve within weeks, can linger for months in an inflamed body. This prolongs pain, delays tissue healing, and contributes to scar tissue formation. Third, and most insidiously, systemic inflammation can interfere with osseointegration, the bonding of an implant to bone, leading directly to the loosening I described earlier. The drivers of inflammaging include processed food, sugar, seed oils, sedentary behavior, poor sleep, visceral belly fat, and chronic stress. Sound familiar? These are exactly the lifestyle factors that accumulate over decades, and they are rampant in the exact demographic most likely to need joint surgery. What can you do? Anti-inflammatory lifestyle changes, particularly in the months before surgery, can meaningfully change outcomes. This means eliminating processed foods, increasing omega-3 fatty acids, optimizing sleep, and working with your doctor to identify and address any underlying inflammatory conditions like metabolic syndrome, autoimmune issues, or insulin resistance. Some surgeons are now using preoperative CRP and IL-6 blood tests, markers of systemic inflammation, to assess surgical risk and timing. Ask about them. Segment 6. Reason number 4. Nerve damage and central sensitization. This next one is something that most patients never hear about, and it breaks my heart a little because understanding it could change how a lot of people experience life after surgery. It's called central sensitization. Here's what happens. When a joint has been painful for years, grinding, aching, inflaming, the nervous system adapts. The brain and spinal cord begin to process pain signals differently. The pain pathways become hypersensitized, like a volume dial that's been turned up too high for too long. When the surgery successfully repairs the structural damage, many patients expect the pain to disappear. And for some, it does. But for others, particularly those who suffered for years before getting surgery, the nervous system has been rewired to experience pain, even when there's no longer a structural source. The joint is fine. The implant is fine. But the nervous system keeps sounding the alarm. This phenomenon is well documented in chronic pain research and is increasingly recognized in post-surgical contexts. A landmark 2018 paper in Pain Journal found that preoperative central sensitization was one of the strongest predictors of persistent pain after total knee replacement, stronger in some analyses than the severity of the original structural damage. What does this mean practically? It means that for some patients, surgery alone will never be enough. The nervous system needs to be retrained alongside the structural repair. Treatments that address central sensitization, including certain medications, graded motor imagery, pain, neuroscience education, mindfulness-based stress reduction, and specific types of physiotherapy, can make a profound difference. But they're rarely discussed in a standard surgical consultation. If you have been in chronic pain for years and are expecting surgery to be a complete reset, please talk to a pain specialist before your operation. Set realistic expectations and build a comprehensive plan. Segment 7. Reason number 5. The recovery window problem. The fifth reason is more practical but just as important. The recovery window is shorter, harder, and less forgiving after 60. After surgery, you have a critical window, roughly the first 3 to 6 months, where the work you do in rehabilitation directly determines your long-term outcome. Move too little, and you lose range of motion, develop scar tissue, and allow muscle atrophy to deepen. Push too hard too fast, and you risk re-injury, excessive inflammation, and implant stress. In younger patients, this window is more forgiving. Their bodies bounce back faster. Sleep is more restorative. Protein synthesis is more efficient. Hormonal support, testosterone, estrogen, growth hormone, is robust. After 60, every one of those factors is diminished. Sleep is often disrupted. Protein metabolism is slower. Hormonal support is reduced. The body is simply less efficient at rebuilding. This means older patients need more structured, longer duration rehabilitation, not the standard 6 to 8 weeks that insurance often covers. It also means nutrition becomes absolutely critical during recovery. Protein intake, specifically adequate amounts distributed across meals, is essential for muscle and tissue repair. Many older adults are chronically under-eating protein, particularly after surgery when appetite is suppressed. Research from the American Journal of Clinical Nutrition suggests that older adults need significantly more protein per kilogram of body weight than younger adults to achieve the same muscle protein synthesis. If you're recovering from surgery, work with a dietitian who understands sports and surgical nutrition. Segment 8. What to do. The complete roadmap. Okay, I've given you the problems. Now let me give you the roadmap. Whether you're preparing for surgery, in the middle of recovery, or trying to figure out why a past surgery didn't work. Before surgery, the preoperative optimization window. 1. Get a DEXA scan to assess bone density. Address low density proactively with your doctor. 2. Start a prehabilitation program. Strength training focused on the muscles surrounding the affected joint. Even 6 weeks makes a measurable difference. 3. Run inflammatory blood markers. CRP, homocysteine, HbA1c if you're metabolically at risk. Work to reduce systemic inflammation through diet and lifestyle. 4. Have an honest conversation with a pain specialist if you've been suffering for more than 2 years. Assess for central sensitization. 5. Optimize nutrition. Enough protein, omega-3s, vitamin D, vitamin K2, magnesium. After surgery, the recovery protocol. 1. Don't stop physical therapy when your insurance runs out. Invest in continued rehabilitation. 2. Work with a nutritionist to ensure you're getting sufficient protein. Aim for at least 1.2 to 1.6 grams per kilogram of body weight daily. 3. Prioritize sleep quality. This is when tissue repair happens. Address sleep apnea if present. 4. Manage inflammation through diet, stress reduction, and follow-up blood work. 5. If pain persists past 3 months, Push for a comprehensive pain evaluation. Don't just accept it as normal. Segment 9. Closing. The bigger truth. Here's the thing I want you to take away from everything we've covered today. Joint surgery, when it works well, is a genuine miracle of modern medicine. These procedures have transformed quality of life for tens of millions of people. I am not here to scare you away from surgery, but surgery is a tool, and like any tool, it works best when the conditions are right. The older we are, the more we need to understand and actively manage those conditions. The reason surgeries often fail after 60 is not because surgeons are bad or because the procedures are flawed. It's because medicine has historically treated surgery as the beginning and end of the story, when really, it's just one chapter. You are the author of the other chapters. Your bone density, your muscle strength, your inflammatory burden, your nervous system, your nutrition, these are not passive factors. They are things you have influence over. And the more you take ownership of them, the better your outcomes will be. If this video helped you, or if you know someone preparing for joint surgery or struggling after one, please share it. This information should not be a secret. I'll see you in the next one.